Okay. Okay, so today I'm going to cover extensor tendon injuries extending from zone 1 to zone 5. So if you look at the extensor tendons of the hand, I truly call this as an incredible structure. Because extensor tendons, we know that they contribute to normal usage of hand, providing us with mobility, stability, strength, and dexterity. We have seen when patients have an inability to extend their wrist or fingers, then they have difficulty placing their hand in space for function. And if you systematically look at the extensor tendon anatomy, right from the origin of the muscles, right down to the insertion of these tendons, we can see that these extensor tendons have quite a complex anatomy. And if you compare biomechanics of the extensor tendons in general, it's a lot more complex. It's very complex because there is a very intricate interplay between extrinsic and intrinsic and also the tendon supporting ligaments such as oblique retinacular ligament, transverse retinacular ligament, triangular ligament, sagittal bands, and so on, because they allow appropriate amount of slippage and motion in order for the hand to function very precisely. However, extensor tendon injuries are still considered trivial. Because of its superior superficial location, extensor tendons are very vulnerable to trauma. And whenever we have heard people say, oh, this is just a small little mallet finger, but it is not. However, these injuries, extensor tendon injuries in comparison with flexors, are not very well researched. But if you look at the number of complications extensor tendons exhibit following an injury, following a trauma, and following the management, if it happens to be inadequate, we see number of complications or associated complications with extensor tendons, so to speak. And looking at the reconstruction or restoration of balance between extrinsic and intrinsic is very difficult, if not impossible, if there are any changes that have occurred at any of these levels, whether it be intrinsic or extrinsic. And the reason behind that is the biomechanics is so complex that getting everything working fine, working again beautifully together becomes very challenging. Extensor tendons have been divided into various zones. The odd numbers, we know that they represent at the joint, whereas even numbers represent in between the joints. Boys added zone 9, that injury is at the musculotendinous junction or proximal. Before we actually begin with managing or discussing extensor tendon injuries of various zones, it is essential for us to understand or truly understand the mechanism of finger extension. When the finger is fully flexed, the lateral bands are volar to the anatomical axis of rotation at PIP, as you see right here. So when your finger is fully flexed, your transverse retinacular ligament is maintaining the lateral bands volar to the anatomical axis of rotation at PIP. Whereas the triangular ligament is somewhat elongated, allowing the adequate amount of slippage of the lateral bands. And then looking at the other structures such as your sagittal band is away from the metacarpal head. So when we initiate extension from a fully flexed position, your central slip of extensor deuterum communis initiates PIP joint extension first. But we know that the lateral bands are connected to the extensor deuterum communis. So as a result, the lateral bands are tensioned somewhat. And as a result, the lateral bands then gradually extend the distal interphalangeal joint. With gradual increase in PIP and DIP joint motion, the extensor deuterum communis start to move proximally. And as extensor deuterum communis moves proximally, it pulls the sagittal band along with it. So as the PIP and DIP joint extension increases, the extensor deuterum communis pulls sagittal band proximally, and in combination with your sagittal band and extensor deuterum communis, then we initiate MCP joint extension. So sagittal band with extensor deuterum communis extend the metacarpophalangeal joint, and especially complete extension of the fingers is maintained by extensor deuterum communis and intrinsics. Now you may see where intrinsics is playing a role in extending the fingers. So especially when you look at the lateral band, they're starting to translate dorsal to the anatomical axis of rotation. The intrinsics also contribute to additional force through medial bands acting at the PIP joint and through the conjoint bands at the distal phalangeal joint, causing it to extend nicely. When the finger is fully straight and held straight, then you can see that forces of extensors, forces of intrinsics and flexors, they pass through the axis of rotation at the PIP, DIP, and metacarpophalangeal joint. So if you look at the mechanism of extension, we can see that the linear force is required to hold the MCP joint extension as well as the last few degrees of PIP joint extension. We need an oblique force required to hold the PIP and DIP joint. And this oblique force is actually coming from the intrinsic muscles, which includes the lumbrical as well, giving you extension of the interphalangeal joint and maintaining the PIP and DIP joint in extension. And jointly together, that means that extensor deuterum communis, that is a linear force, and oblique force produced by the intrinsic, they jointly act together, maintaining the finger extension. You can see how the mechanics is quite complex. So we can very well say, based on these discussion that I gave earlier, the extension of the phalanges over metacarpal, therefore, is as a result of intricate extrinsic and intrinsic extensor balancing act. So they are balancing the mechanism very nicely, allowing us to retain extension at all the three joints. We know that the extensor tendon injuries often are considered trivial. But if you look at the complications, we can see that injuries in any zone may produce different complications. Commonly, what we see is extensor tendon adhesion that are the most common problem with extensor tendons. We see extensor tendon tightness, not allowing us to perform composite flexion of the metacarpophalangeal joints as well as interphalangeal joint because of adherence. And at times, inadequate or improper management may result into extensor tendon ruptures. However, besides these common complications, such as Swan neck and boot neck deformities presently, or they challenge us even more. But we never ever considered unrecognized or unreported joint compressive forces. For example, the picture that you see on top, the person has an extensor tendon repair at zone 5 that was immobilized for 4 to 6 weeks period of time. The whole entire extensor tendon as well as the sagittal band has scarred down, enabling the patient to perform a flexion of the metacarpophalangeal joint and interphalangeal joint. So as a result, the person has significant amount of joint compressive forces and patient has quite a bit of pain. So the video that you see on the left-hand side, you can see this patient had first extensor compartment tendons repaired. And as a result, the tendons had difficulty gliding beneath the extensor retinaculum. You can see that the person is able to perform some radial deviation. However, ulnar deviation is just not possible because of lack of or loss of freedom of tendon motion beneath the extensor retinaculum. So as a result, there are numerous changes that have occurred as a result of these tendon adhesions. There are joint compressive forces, and this patient had lost mobility of the radiocarpal as well as intercarpal joint or midcarpal joint, and therefore compressive forces were relatively quite significant. So now we'll go through systematically from zone 1 onwards and discuss these injuries. The mechanism of injury is well known. It's a hyperflexion of the distal phalanx. The impact is so severe that you may have either pure tendon rupture, as you see in the first X-rays, or patients may have a bony mallet, having a bony fragment getting pulled off proximally. So most commonly we see ruptures or avulsion. So, or it may be caused by laceration of the terminal tendon, as you see right there, or laceration of single or both lateral bands. So Doyle introduced a classification system. He divided these injuries into different types. Therefore, type 1 is closed injury, whereas type 4 is a mallet finger fractures. And this classification was modified by Lin and Samora. They added additional classifications such as 4ABC and 5ABC, and that consists of fractures of the distal phalanx as category 4 of fractures, or open injuries such as seen in type 5 as shown in this pictures. So management, we know that it is literature mentions that closed injury should be managed by splinting. However, the literature also supports that some closed injuries require surgical intervention, such as this, where there is a complete dislocation of the fractured fragment in relation to the parent body, and the distal phalanx has gone in somewhat inferior subluxation in relation to the middle phalanx. However, all open injuries must be managed with surgical intervention. Now, considering the limiting factors, we are not going to talk much about the surgical intervention of various anatomical injuries. However, we'll cover some where I feel that it's appropriate to discuss these issues from the therapy point of view. Interestingly, there are 400 or over 400 publications on mallet finger. And what I found that researchers focused on comparing different types of DIP joint or DIP immobilization splint. Even though there are only limited studies that have randomized or performed blinded or controlled trials, they were totally missing the complication that we commonly or often see with mallet finger injuries. There is only one publication that divides the management into two different stages, focusing on specifics that has a stabilization effect for the swan neck tendency. So in general, everybody who's looking at these papers and reading those may come out and may say that overall the research on mallet finger is very unsatisfactory. So Cochrane review identified that there is an insufficient evidence, especially looking at the relative effectiveness of different types of splints. And also they identified that all the publications that is pertaining to mallet finger were insufficient in terms of giving us an evidence when the surgery is indicated, especially with the type 1, type 2, and type 3 injuries. So traditionally, what we have been doing lately for last about 25 plus odd years is we are splinting the DIP joint. And the common type of splint that we have been using is DIP immobilization splint, and most commonly used is the stack splint. However, one must know that stack splint doesn't fit every finger. And there are quite a few papers that talk about custom molded splinting. However, if you look at the literature, you'll see a slew of splint designs people have used and did study on those, looking at comparison between stack splint versus custom molded splint and so on and so forth. But ultimately, DIP joint immobilization alone does not do any justice to the mallet finger injury. We ultimately see that these patients end up getting a swan neck deformity. It's unpleasing to these patients. However, we must look at that what exactly transpires after, even though DIP joint is splinted for certain length of time. So a look at systematically the biomechanics of swan neck deformity. So it has been shown that detachment of terminal tendon causes recoiling of the terminal extensor tendon. In addition to that, because we know that the spiral oblique retinacular ligament also is attaching at the distal phalanx just adjacent to the terminal tendon. Upon detachment of the terminal tendon, there is a sudden retraction of the spiral oblique retinacular ligament. And combined vectors of intrinsic forces through the medial band, and of course the forces of the central slip jointly together produces a hyperextension load of the middle phalanx in relation to the proximal phalanx, causing a swan neck tendency as it is. So from pathomechanics point of view, despite of us using a static DIP joint splint alone does not do any justice to the excessive load that is transmitted at the PIP joint. And ultimately, the distal portion or detached portion end up having a gap scar formation. Now, when there's a gap scar formation at the terminal tendon, distally, there'll be an altered length tension relationship between the terminal tendon and flexor deuterum profundus. The flexor deuterum profundus is at a greatest advantage because there is nothing opposing adequately on the dorsal side, and therefore the tendon, profundus tendon, tends to cause flexion of the distal phalanx. And then we can probably say that the proximal motion of the distal phalanx in a retracted manner is going to produce tension on the lumbrical that is originating from the flexor deuterum profundus, adding additional tension at the PIP joint, magnifying the forces at the PIP joint because there is a disturbance of length tension relationship between these two tendons. So looking at the reference, the rehab of the hand, volume 3 by Tubiana, chapter 12 describes this pathomechanics beautifully. When I graduated back in 1971 and started working as a hand therapist in 1972, back then, of course, we had to position all mallet fingers into a splint or a cast, keeping the PIP joint in flex position and DIP joint in extended position. However, we kept the PIP joint in 60 degrees and DIP joint extended, and I identified, all of us identified that PIP joint, because being in so much of flex position, it ended up having PIP joint flexion contracture, and that was quite challenging in order to manage afterwards. So Stack identified that extensor system is in a form of a diamond. Similarly, the Winslow's diamond Winslow also identified that the shape of the extensor system is in a form of a diamond. So let's see, based on the diamond of Stack or diamond of Winslow, how we describe this pathomechanics leading to secondary swan neck deformity. So here we have a rupture of the terminal tendon, which causes FDP to flex the DIP joint. And as I mentioned earlier, that it probably is contributing to increased amount of lumbrical load because the lumbrical moves along with whatever motion or retraction the flexor deuterum profundus has. And then when we see that the load of intrinsic or medial band and MCP joint or sagittal band, sorry, not sagittal band, but intrinsic load produced by the medial band and extensor deuterum common is the central slip, is excessively loading the PIP joint, causing PIP joint to hyperextend. And this is what we see normally, that despite of giving patients that only DIP splint, it doesn't balance the forces at the PIP joint. So therefore, it is essential for us to radiologically look at the posture of the PIP joint, because we often pay attention to the distal phalanx and its posture in relation to the middle phalanx. And we can say that, yes, that upon detachment of the terminal tendon, it's very likely that PIP joint will ride in hyperextension. And we can see that number of us have hypermobility at the PIP joint as it is, and upon detachment of the terminal tendon, immediately the finger will go into a zigzag collapse. So how do we address mallet finger deformity or swan neck deformity? It's based on the established goal that from the therapy point of view, we want to reduce the deforming forces at the PIP and DIP joint. So how do we treat these patients in our clinical setting now? That upon looking at these postures, we use an adhesive tape, bringing the DIP joint in slight hyperextension, and then applying a tubing net over the skin in order to cover the finger, and then use Orphe cast or quick cast, fabricate a cast for the finger, maintain the PIP joint in about 30 degrees of flexion, and DIP joint slightly hyperextended. And then patient is given this cast, and then the cast is replaced once a week. The reason for that is just to monitor the skin condition so that to ensure that there is no skin breakdown whatsoever. So if you look at the chapter written by Tubiana, it has shown that by bending the PIP joint in flexion, you're already relaxing the tension on the lateral band. The lateral bands are somewhat closer to the anatomical axis of rotation. And then by keeping the PIP joint slightly flexed and DIP joint extended, you can approximate the tendon ends closer to each other. And even though the person may have a fracture or bony mallet, you can approximate the bony fragment to the parent body much closer so that there is an adequate and appropriate healing. So how do we treat these patients? Patients are given a cast, which is replaced once every week. The cast maintains the PIP joint in 30 to 40 degrees of flexion, DIP in slight extension. And when we perform the cast, when we make another cast the following week, we'll allow these patients to perform passive range of motion of the PIP joint only, keeping the DIP joint maintained in extension, going from 30 degrees to full flexion. And then this cast is replaced once every week by a splint. So this is the type of the splint that we use. And then from between 4 to 8 weeks, we continue with the finger-based dorsal orthosis, same posture as we had before in the cast. And then patients perform daily range of motion of the PIP joint with the short splint. And we give specific instruction to these patients about do's and don'ts and the number of repetitions they should perform on what frequency basis. And then between 8 and 12 weeks, patients are given DIP joint splint alone intermittently throughout the day. And then they continue moving their PIP and DIP joint exercises on every 2-hour basis. However, we strongly recommend that patients do not perform resisted flexion of the fingers till at least 8 to 10 weeks following their first application of the splint. If they have to use resistive exercise, resistive motion of the fingers, we encourage these patients to continue wearing the splint so that whatever healing had happened as a result of the splinting and casting that we have given these patients, we do not cause any disruption of the terminal tendon. And we continue to use a nighttime splint, and the posture is again the same, keeping the PIP flexed and DIP joint hyperextended. So results of this management is excellent, and we are quite happy with the management that we have. We are collecting the data right now and then submitting our results for publication. So Crawford introduced his classification system, looking at how we should rate the mallet finger outcome. So excellent is when patients have full extension and flexion with no pain. Good is if patients have extensor deficit 10 degrees or lesser and have full flexion, however, they have no pain. Fair is when patients have 25 or up to 25 degrees of extensor deficit, but no pain. And poor is the same, that there is an extensor deficit greater than 25 degrees limited flexion, and of course, that is associated with pain. But if we look at this classification in terms of mallet finger outcome measurement, is this really the case, or should it be modified based on the type of management that I've described? So I'm going to bring a quote from the Pulver-Taft Institute itself, which was published on presented on 6th February 1948. So Dr. Pulver-Taft mentioned that the splint must be accurate and maintained for 6 to 7 weeks. The plaster should be molded, or patient should be given an aluminum splint that should include full length of the digit, maintaining the proximal interphalangeal joint in flexion and the distal interphalangeal joint in extension. So this is already shown to be effective by Guy Pulver-Taft, and there's another paper by Stark which also showed that bringing the PIP joint in flexion and DIP joint in slight extension definitely performs a balancing act between the extensors and flexors, and therefore the results are much better. Now we'll discuss the zone 3 management. So looking at the mechanism of injury, we know that it's often caused by impact on the middle phalanx. And as a result, the central slip ruptures, either with pure tendon rupture or avulsion with the associated fracture. And often you'll see that patients have an inability to extend the PIP joint, as you see in the video on the left-hand side. It's quite likely that depending on the extensor load at the time of impact, patients may have a small little chip fracture that often is not paid attention to following an injury, and later on that magnifies over time. Or patient may have a bigger chunk of the extensor tendon middle phalangeal dorsal lip fracture that may result into a Buchner deformity as well. Or the injury could be caused by laceration of the central slip of extensor deterrum communis. So Tubiana and Valentine in 1969 introduced a classification by identifying various deficiencies in terms of finger extension at the PIP joint and various contribution of various anatomical structures that have undergone adaptive shortening. So stage 1 is minimal but correctable deficiency in extension. Usually it is less than 30 degrees. There may be a moderate subluxation of lateral bands. However, these are recoverable if you bend the DIP joint so that lateral bands translate dorsal to the anatomical axis of rotation. If the patients are left untreated in stage 1, they'll progress to stage 2. And in stage 2, they're going to have some contractures of the middle extensors. The lateral bands will remain below the axis of rotation, and patients are likelihood of having some amount of PIP joint flexion contraction. If the patient is still not managed from the therapy point of view, then they'll progress to stage 3, where they'll have contractures of retinacular ligaments, but they'll have a positive retinacular test. And if still not managed for a certain length of time, then patients will end up having fixed flexion contractures of the PIP joint and DIP joint hyperextension contractures with severe adaptive shortening of numerous anatomical structures. So Tubiana and Valentine identified that this is Buchner deformity is progressive condition and therefore must be paid attention to right from stage 1 or later stages. Burton also introduced a classification which is somewhat similar to what Tubiana had. So again, I'm bringing the volume 3 to everybody's attention. That's an excellent book which has beautiful description of Buchner deformity and the management from the management point of view as well. So we know that upon central slip avulsion, laceration, or rupture, the lateral bands fall volar to the anatomical axis of rotation. There's an increased intrinsic load that is acting on the distal interphalangeal joint, and that produces hyperextension tendency at the DIP joint, and PIP joint stays in flex position. So when we look at the Dimond of stack and or Winslow's Dimond from the pathomechanics point of view, you can see that when there is a rupture of the central slip, FDS pulls the PIP joint in flexion, and the forces of the intrinsics as well as the extensor deuterum communis through the lateral bands tends to produce hyperextension tendency at the DIP joint. So again, we have a zigzag deformity. PIP stays in flex position. DIP joint goes in hyperextension, and every attempt that is made to extend the PIP joint, the MCP joint will demonstrate a tendency to hyperextend. So in other words, the Dimond, whether it be of Dimond of stack or Dimond of Winslow, the Dimond widens because the lateral bands are pulled polar to the anatomical axis of rotation. And of course, we're going to have PIP flexed posture, DIP and MCP joint hyperextension. So this particular injury requires critical evaluation before making a decision regarding splinting or management. So from the clinical examination point of view, Bowier's or Boy's tests are most appropriate in central slip rupture, especially when the injury is acute. The Elson test is not suitable for acute injuries. The reason being that if you are allowing or pressing on the middle phalanx to assess whether the central slip is intact or not, is quite likely the tendon may not have completely ruptured or avulsed from the site of its insertion. But by pressing the PIP joint or middle phalanx in flexion and asking a person to extend the DIP joint may result into rupture, which has not occurred before, but now rupture as a result of testing by the individual. So I put these patients through critical evaluation. I look at the finger, especially to see whether they have any acute extension of the PIP joint. I'll ask the person to extend the PIP joint passively and see whether the person is able to retain the extension and for what length of time. So here, of course, surprisingly, when you extend the PIP joint and ask a person to hold, he's able to hold the finger PIP joint in extension for a very short period of time. But ultimately, because we know that PIP joint is also extending because of the intrinsic load is basically attempting to maintain the middle phalanx in extension. However, the central slip, because it's deficient or not present, is incapable of maintaining the relationship of the lateral bands and central slip together because central slip is just not there. So in this situation, you can see that by extending the finger passively and asking a person to extend, the lateral bands are somewhat closer to the anatomical axis of rotation. However, if you look at the posture of the DIP joint hyperextends, but central controlling mechanism is absent, which is incapable of retaining the lateral bands above the joint axis at the PIP joint, and therefore gradually the finger falls in flexion, as we see in this classic video. And then another test that I perform is by flexing the MCP joint. I want to see whether a person is able to extend the PIP joint at all or not at all. So you can very well see that by placing the MCP joint in flexion, PIP joint extension doesn't improve at all. And now another test I'll do is place the MCP joint in flexion, passively extend the PIP joint, and ask the person to maintain. And the person is capable of holding the finger in extension at the PIP joint for a very short while. Again, we know that the deficiency is because of central controlling mechanism that is offered by the central slip is just not present for the finger to remain in extended position. And of course, the last phase will be to assess the spiral oblique retinacular ligament by keeping the MCP joint flexed. Now, many times patients will have difficulty extending the finger, as you see in this particular individual. You can see that the PIP joint is trying very hard to extend the PIP joint, but is unable to extend the PIP joint at all. In such situations, I'll fabricate a small little splint for testing, and then placing the DIP joint in slight flexion, I noticed that patient has some ability to extend the PIP. Now you may wonder why DIP joint splint is allowing him to extend, because we know that once you flex the DIP joint, you're gradually bringing the lateral band somewhat closer to the anatomical axis of rotation. So this particular test, by placing the DIP joint in flexion and patient's ability to extend somewhat, is suggestive of patient having triangular ligament attenuation. So now, after doing all these tests that I have shown you, concludes or gives me an idea that the patient must be positioned in a specific manner so that we create a balancing act between all these tendinous structures that are responsible for giving these patients complete extension of the PIP as well as DIP. So the treatment of Buchner based on my examination is that I'm going to place the metacarpophalangeal joint in flex position. I want to maintain the PIP joint in full extension and leave the DIP joint free for a period of 2 weeks period of time. So here, of course, this examination suggests that by flexing the MCP joint, PIP joint extends somewhat and allowing the person to perform the DIP joint flexion exercises whereas PIP joint is held in neutral constantly throughout this process. And then DIP joint active range of motion within the splint will encourage the DIP joint to flex. And then there are certain other advantageous action that goes on when you allow a person to flex the DIP. And after 2 weeks, I'm going to, I'll provide these patients with the circumferential splint, which maintains the proximal phalanx and middle phalanx stationary, leaving the DIP joint free for active flexion. So primary goal of therapy in acute injuries, it's important that we consider Burton's and Tubiana stage 1. The primary goal is to reestablish central slip insertion at the PIP joint. 2, retain the lateral bands dorsal to the axis of rotation at the PIP joint. And 3, reduce the deforming forces at the PIP and DIP joint. So by placing the MCP joint in slight flexion, we know that the lateral bands will translate above the axis of rotation at the PIP joint. As you see, when the central slip is dissected out, you can see that the lateral bands, by placing the MCP joint in flexion, will translate dorsally at the axis of rotation. So MCP joint in flexion causes relaxation of long flexors and intrinsics. 2, the lateral bands translate dorsally with the flexion of the MCP joint. And of course, this gives me a clearer idea as to how much extensor lag we have at the PIP joint. The advantages of leaving the DIP joint free is when the patient performs DIP joint flexion, then spiral oblique retinacular ligament length is retained. The flexor determinum profundus glides proximally as well as distally. There's a dorsal translation of lateral bands. It maintains the relationship between transverse retinacular ligament and triangular ligament. It also prevents dorsal capsular tightness at the DIP joint. You can see there are many advantages by placing the PIP joint in neutral and allowing the person to perform DIP joint extension and flexion. So results with these acute managements are excellent. You can see that the person has great extension of the PIP joint. However, in this situation, patient demonstrates that he has incomplete PIP joint extension, and that is mainly due to the subtendinous adhesions between the central slip and the dorsal joint capsule. So this definitely, if we ignore this at this point, the patient will end up going into a Buchner posture again, despite of central slip healing. So therefore, to treat extensor lag, if present, patient should be fitted with the relative motion flexion splint to gain full active PIP joint extension so that the intricate relationship between the medial bands of intrinsics, the lateral bands and its retention dorsal to the anatomical axis of rotation, and excursion of the central slip is well maintained through the management that I've described. Nowadays, people are using relative motion splinting for the management of central slip rupture. But let's look at whether this is a safer method to manage the central slip rupture. In my opinion, no, because allowing patients to move the PIP joint in a relative motion splint will constantly move the central slip and the site of insertion away from each other on a regular basis. And especially the central controlling mechanism, that is central controlling the central slip, or central controlling arm, will be somewhat longer than the flexors, and therefore the forces of flexors will not be able to be balanced on the dorsal side. So as a result, patient will have a gap scar formation between the insertion side and the central slip. And when the person has a gap scar formation, the extensor side will be a bit longer. Flexors will always be advantageous. We know that the flexors are 4, if not 6 times stronger than extensors. The flexors will always take over, and consequently, the lateral bands will fall volar to the joint axis. Patients will end up having PIP joint flexion contracture. Patients will have spiral oblique retinacular ligament tightness and recurrence of Buchner deformity. So keep in mind that relative motion flexion splint will be ineffective in many situations, especially if there is a gap scar formation at the tendon end, 1. If there's an attenuation of the triangular ligament, that's 2. If the patients have gone into contractures of spiral oblique retinacular ligament, transverse retinacular ligament, or in other words, the soft tissue contractures will not allow the relative motion splint to work effectively. And again, if the person has a dorsal joint capsular tightness, will not be resolvable with relative motion splinting. So we looked at the acute management of acute injuries. Of course, if the patients have had tendon transection, how do we manage the central slip repairs? So here, of course, we did cadaver dissection, sutured the central slip. And then, of course, by placing the MCP joint in slight flexion in a relative motion splint, yes, we can successfully treat the laceration or repairs of central slip by using by using relative motion splinting. So we begin with active short arc of motion of the PIP joint. We allow patients to perform DIP joint flexion exercises. We monitor extensor lag and PIP joint flexion contractures, and we treat those accordingly. My recommendation is patients do not use tight grip for good 8 weeks rather than 6 weeks following the central slip repair. So institution of short arc motion splint is quite effective. Patients do not require an elaborate splint. We can give them a template splint, as you can see right here. We encourage the patients to perform flexion, active flexion and extension of the PIP joint, flexion limiting to only 30 degrees in first week, and then 15 degrees increment on a weekly basis. But keep in mind that if the lateral bands are repaired also, we need to maintain the DIP joint in neutral as well. And then, of course, gradually, if it's only the central slip and not the lateral bands, then you allow gradually increased amount of motion of the PIP and DIP. And then, of course, DIP joint flexion with the PIP joint held in neutral. So patients may require different types of exercise splints as well as template splints for them to successfully follow this short arc of active motion program following a repair of zone 3 as well as zone 4. So management of chronic Buchner deformity is dependent on stage 2 involvement, stage 2, stage 3, or stage 4 involvement. However, we know that depending on the time lapse from the time of injury until these patients are seeking medical attention, we have some varying degree of soft tissue contraction. So stage 3 may require surgical release or reconstruction, and similarly, stage 4 may require some release as well as reconstruction also. So it's important for us to understand the chronicity of the boot nail deformity. The patient who is injured is treated by some coach or standbys in the arena. Patient's exact diagnosis was not established. Patient did not seek medical attention. And then detailed history will reveal the fact that patient had delayed management. So if the patients have persistent inability to extend the PIP joint, there'll be an adaptive shortening of number of anatomical structures that are listed here. And therefore, these patients are the best candidate for specific management. So from the assessment point of view, it is important that we assess the active and passive range of motion of the DIP joint. We look at the passive PIP joint extension and identify those limitations. We'll also check for various other anatomical structures that is giving us retention of the PIP joint in flex position. However, we must identify what type of a springy and feel these patients are exhibiting. And that we can do by performing various tests and then looking at the retinacular test. So these are some of the characteristics that you're going to see in a chronic condition. So the treatment options is using thermal modality to increase viscoelastic properties of the soft tissue. We go on to joint mobilization, passive PIP joint extension, passive DIP joint flexion, when the PIP joint is held in neutral, and then we give patients a specific home exercise program with frequency and duration of the program that they must perform. And then if they should be given different types of splints depending on the type of limitation these patients are exhibiting. So treatments from splinting options point of view, it's based on end feel. You may consider giving Kapner or spring wire or LMB splints during the day or night extension splint. And then, of course, these splints need to be modified as the patient makes gains by the splint application. So progression of therapy, once we have gained PIP joint extension to neutral, then we follow the same routine that holding the PIP joint in neutral, allowing patients to perform DIP joint flexion exercises. The management is exactly the same as I described with acute injuries. And then later on, we begin with a range of motion exercises, initially as permissible, and then they follow routinely these programs. And it's very important that these patients definitely will require relative motion splinting. And surgery is indicated if the PIP joint is unattainable. Extensor zone 4 injuries are relatively rare. I probably may have seen about 5 or 6 cases in my whole entire hand therapy career. However, based on what I saw clinically in my clinical practice, it's important that we consider the anatomy of the extensors. We have a sagittal band at the metacarpophalangeal joint. The extensor tendon divides into 3 slips, central slip and 2 lateral bands. And then, of course, the central slip inserts on the middle base of the middle phalanx. But what we often forget is if it is an index finger, we may have an involvement of extensor indus proprius. Or if it is the small finger, we may have an involvement of extensor digiti minimi in a small finger. So looking at some of those cases that I've treated in the past, I came across that the injury was somewhat different in all the 5 cases. The tendon laceration may be when the finger is in an extended position. In such situation, it's quite likely that the transection or tendon laceration may be just proximal to the PIP joint, or the tendon laceration may be in the central region where you may have central slip and lateral band involvement, or distal to the metacarpophalangeal joint where you have just EDC central slip laceration. If the injury is in a finger flexed position, you may have central slip and lateral bands involvement or central slip only. And if it is an index or small finger, you may have involvement of EIP and EDM. So common complications in zone 4 is definitely limited extensor and intrinsic gliding proximally or distally. It's quite likely patients may have boot nail deformity, which may be of a fixed nature or mobile nature, depending on the length of time patient did not seek medical attention. Patients will have extensor lag at the PIP or DIP joint. Patients' PIP joint and DIP joint may be somewhat stiffer. So based on the mechanism of injury and our understanding of the anatomical structure, the management somewhat is the same. So if it is just the central slip, the management is similar to zone 3, what I have described. If there is a central laceration which involves the lateral bands, we must provide these patients with the full finger splint, with DIP splint for mobilization, allowing these patients to perform short arc of motion, because all these patients require surgical repairs. Patients must perform isolated MCP, PIP, and DIP joint exercises. But while you are moving the DIP joint, while you are moving the PIP joint, make sure that the DIP joint is splinted. And injuries distal to the MCP joint, of course, the management can be with the ICAM splint. If the finger injury is in a finger flex position, if the central slip is repaired, I've already described the management earlier. If it is a central slip, we know that we have to manage these patients similar to zone 3. However, if it is an index or a small finger, it's important that we encourage these patients to have differential tendon motion or tendon gliding between EIP and EDC. And if it is a small finger, differential EDM gliding and EDC. So the management is based on which anatomical structures are repaired. Repairs are usually in a form of double Kessler or double figure of 8 or running interlocking horizontal mattress. So they are relatively much stable repairs, and therefore controlled mobilization must be implemented in order for us to have gliding of the extensor tendon proximally as well as distally. And you may decide based on the type of repair these patients have, you may initiate short arc of motion to 45 degrees at MCP, 30 degrees at the PIP joint, and 15 degrees of the DIP joint, and 15 degrees on an incremental basis. And after about 4 to 6 weeks period of time, you can initiate this composite flexion. So at 4 to 6 weeks, we can begin with combined motion of all the 3 joints to 3 to 1 finger distance, linear distance from the distal palmar crease. It's important that we monitor and treat extensor lag and PIP joint flexion contracture. We can begin with strengthening at 8 weeks. It's important that we mobilize extensor DT minimi EIP separately from extensor deterrum communis. And if there are multiple fingers involved, such as this patient, we can use a reverse Lionard technique for mobilization of these tendons. Now we'll go on to management of zone 5. We know that zone 5 anatomy consists of various anatomical structures and its vicinity. We have sagittal bands that connect to the volar blade. And again, on index, we have extensor indicis proprius. And on small finger, we have extensor digiti minimi. So traditional management, these patients were traditionally managed with the volar splint for 4 weeks. There are various protocols which have been written in the past, keeping the wrist in variable extension, MCP, and IP joints in variable extension, and of course, either leaving IP joints in complete extension or free to move. So looking at some of these management that have been described, I have used that personally, clinically. I identified that if you are maintaining the wrist in extension and MCP is in neutral, PIP joint had a tendency to fall in flexion because of the tenodesis act, and therefore patients had strong tendency to go into PIP joint flexion contraction. So positioning of these fingers is in extension is essential in order to prevent flexion contraction. The complications of these include tendon adhesions, as you see right there. And if the extensor tendon has limited proximal gliding at the metacarpophalangeal joint, then patients are going to have an extensor lag at the metacarpophalangeal joint, which will ultimately go on to developing extensor quadriga. And this extensor quadriga eventually will lead into secondary swan neck deformity as a result of adaptive shortening of intransic. Or patients may have a loss of composite flexion of MCP, PIP, and DIP joint because of immobility. So how do we manage this in order to prevent these complications that I've listed earlier? That upon repair of the tendon in zone 5, as advocated by Mallet and Howell, we give them an ICAM splint or yoke splint and allow these patients to perform active motion of the MCP and IP joint. However, now the trend has been to use an ICAM splint only and not the wrist splint. And if you don't use the wrist splint, then of course it's quite likely that these patients may have a tendon rupture. Our next session on extensor zone 6 and proximal, I have classic videos or cadaver videos to demonstrate that if you do not use the wrist splint, then how much tension is produced at the repair site. But anyway, this is an ICAM or yoke splint. Involved finger is kept in somewhat greater extension than the adjacent digits. We encourage these patients to perform active MCP and IP joint range of motion. The splint is used for a period of about 6 weeks. We encourage these patients not to perform any strengthening exercises for 12 weeks period of time, and the results are quite remarkable. So it's important that we continuously monitor and prevent PIP joint flexion contractures, because some extension of the involved finger in relation to adjacent digits will cause the PIP joint to droop in flex position, and that will lead to PIP joint flexion contractures. So intermittently, patients' PIP and DIP joints should be held in neutral within that same splint again. So there are different types of splint design. As you can see, if there's a border fingers, then we need to keep the central two fingers in flex position and border fingers such as index and small finger somewhat in a hyperextended position. So here this patient had somewhat longer splint, and of course that needs to be trimmed to allow the PIP joint range of motion. So the posture of the finger should be such that for D3 and D4, for example, ring and long finger should be kept in hyperextended position in relation to the index and long. So this is the yoke preference design. For long finger, again, the long finger should be somewhat hyperextended than adjacent fingers. And if it is ring finger, then ring finger should be somewhat more in extension as compared to long and small finger. So the results are remarkable. As you can see right here, this patient had long finger zone 5 extensor tendon injury. So in conclusion, the extensor tendon injuries are considered trivial, but they truly are not. The extensor anatomy is a lot more complex, and of course the biomechanics is even more complex than flexors. However, therefore, the extensor tendon injuries should not be ignored. The extensor tendon mechanism is much more complex, and therefore construction or reconstruction or restoration of this balance between intrinsic and extrinsic is difficult, if not impossible. So therefore, extensor tendon management must be critical in order to avoid any of these complications that I have listed here. Thank you very much.